In the chaos of war, where nations clash and ideology divides, there exists a code that transcends the front lines. It is written not in treaties or doctrine, but in the actions of those who choose mercy over vengeance, healing over hatred. This is the story of how American combat medics, amid the brutality of World War II, fought not to take a life, but to save one. Their patient was not a fellow soldier, not a civilian caught in crossfire, but an enemy combatant, a German prisoner of war whose shattered leg threatened to end not just his ability to fight, but his ability to walk. The year is 1944, and Europe is engulfed in the final, desperate stages of the Second World War. Allied forces have broken through the Atlantic Wall and are pushing deep into occupied territory. The German Wehrmacht, once seemingly invincible, now fights a retreating battle on multiple fronts. In the forests of France and the frozen fields approaching the Rhine, American and German soldiers meet in combat that is as brutal as it is relentless. Every day brings new casualties, new horrors, new tests of human endurance. In this landscape of destruction, the American Medical Corps operates under a principle that many would find paradoxical. They are sworn to provide care to all wounded, regardless of uniform or nationality. The Geneva Convention demands it, but more than that, the medical oath requires it. Yet in practice, when resources are scarce and American boys are dying, when the enemy has inflicted unspeakable losses, the commitment to treat captured German soldiers with the same dedication as their own becomes a profound test of humanity. This particular case would become legendary among the medical units serving in the European theater. A young German soldier, barely out of his teens, had been captured during a fierce engagement. His injuries were severe, a compound fracture of the femur complicated by extensive tissue damage and infection. In the field hospitals of that era, with limited antibiotics and overwhelming caseloads, the standard protocol was clear and unforgiving. When a limb could not be saved quickly and efficiently, amputation was the only option. It saved lives by preventing the spread of gangrene and sepsis, and it conserved precious medical resources for those with better prognosis. But a team of American medics saw something in this young German that others might have missed. Perhaps it was his youth, his fear, or simply the universal human desire to preserve what could still be saved. What followed was an extraordinary effort that would push the boundaries of battlefield medicine, challenge the prejudices of war, and demonstrate that even in humanity's darkest hours, compassion can prevail over hatred. This is the story of how skill, determination, and an unwavering commitment to the healer's oath turned what should have been a routine amputation into a fight for a leg, a life, and the very soul of medical ethics in wartime. To understand the significance of what these American medics attempted, one must first understand the brutal realities of battlefield medicine in World War II. The Medical Corps of the United States Army had evolved significantly since the First World War, but the challenges remained immense. Combat medics operated in a hierarchy of care, beginning with the aid men who crawled through machine gun fire to reach the wounded, continuing through battalion aid stations just behind the lines, and culminating in field hospitals and evacuation hospitals in the rear areas. The American military medical system was built on a philosophy of rapid evacuation and staged care. Wounded soldiers received immediate first aid at the point of injury, stabilization at forward positions, and increasingly sophisticated treatment as they moved back through the medical chain. This system saved countless lives, but it was not designed for prolonged, complex interventions. Resources were finite, personnel were stretched thin, and the constant influx of casualties meant that difficult decisions had to be made quickly. Captain James Morrison, a surgeon from Ohio, commanded the field hospital unit where the German prisoner arrived. Morrison was 34 years old, a veteran of the North African Campaign and the Italian Front. He had performed hundreds of amputations, each one a small tragedy that haunted him in the quiet moments between surgical shifts. He had seen young men wake from anesthesia to discover they would never walk, run, or dance again. He had written letters to families back home, choosing words carefully to soften truths that could never truly be softened. The German soldier, whose name was recorded as Hans Richter, arrived at Morrison's field hospital on a cold November morning. He had been wounded 3 days earlier during an engagement near the German border. His captors, American infantry from the 3rd Armored Division, had provided basic first aid and evacuated him according to protocol. By the time he reached the field hospital, his condition had deteriorated significantly. The compound fracture had become infected, and the early signs of gas gangrene were beginning to appear. Gas gangrene was the nightmare of every battlefield surgeon. Caused by bacteria that thrive in deep, contaminated wounds, it produces toxins that destroy tissue at an alarming rate. Left untreated, it spreads rapidly and kills with brutal efficiency. The standard treatment was immediate amputation above the infected area, followed by aggressive debridement and sulfa drugs if available. In Richter's case, the infection had spread far enough up the thigh that a high amputation, close to the hip, would be necessary. Morrison examined the young German with the clinical detachment that war had taught him to maintain. Richter was conscious, feverish, and terrified. Through a translator, he begged the American doctors not to take his leg. He spoke of his family, his mother, his dreams of returning home to study engineering. Morrison had heard similar pleas from American soldiers, and they never got easier to hear. But there was a difference here that Morrison could not quite articulate. Perhaps it was the boy's youth, or the particular desperation in his eyes, or simply the accumulated weight of too many amputations performed on too many young men. Staff Sergeant Robert Chin, a surgical technician who had trained at Johns Hopkins before the war, stood beside Morrison during the examination. Chin had a reputation for technical brilliance and an almost obsessive attention to detail. As Morrison prepared to schedule the amputation, Chin quietly suggested an alternative. What if they attempted a radical debridement, an aggressive surgical cleaning of the wound that might save the leg? It would require hours of surgery, careful dissection to remove all infected tissue while preserving vital structures, and a gamble that the newly available penicillin could control what remained of the infection. Morrison's first instinct was to refuse. The procedure Chin described would consume resources desperately needed for American casualties. It would tie up the surgical team for most of a day. And even if they succeeded in cleaning the wound, there was no guarantee the leg could be saved. Richter was a prisoner of war, likely destined for a POW camp where medical care would be minimal. Wouldn't a clean amputation and a prosthetic be more practical than a damaged leg that might never function properly? But something in Chen's quiet insistence gave Morrison pause. The sergeant was not motivated by sentiment, Morrison knew. Chen approached surgery with the precision of an engineer solving a mechanical problem. If Chin believed the leg could be saved, his assessment was based on technical feasibility, not emotion. Morrison looked again at the young German, seeing past the enemy uniform to the frightened teenager beneath. He thought of his own son, safe at home in Cleveland, and made a decision that would define his career. They would attempt to save the leg. The surgery began at 1400 hours on a gray afternoon that threatened snow. Morrison assembled his best team. Chin would serve as first assistant, with Lieutenant Mary Patterson, one of the Army nurses attached to the unit, managing the instruments and monitoring the patient's vital signs. Corporal David Martinez would handle anesthesia, a critical and dangerous job given the patient's weakened condition and the length of the planned procedure. A young medic named Private First Class Thomas Riley would serve as the circulating assistant, fetching supplies and maintaining sterile protocol. The operating theater was a converted barn that had been requisitioned from a French farmer weeks earlier. The Army had installed surgical lighting, running water, and heating stoves, transforming it into a functional if primitive surgical facility. The smell of antiseptic mixed with the faint odor of livestock that still clung to the wooden walls. Outside, the distant rumble of artillery provided a constant reminder that the front lines were never truly far away. Richter was placed under general anesthesia using a combination of ether and pentothal. Martinez worked carefully, knowing that the patient's fever and infected state made him particularly vulnerable to complications. As Richter's breathing settled into the steady rhythm of unconsciousness, Morrison made his first incision. The wound was worse than the external examination had suggested. The original injury had shattered the femur and driven fragments of bone deep into the surrounding muscle. Dirt, fabric from the uniform, and other debris had been ground into the tissue by the force of the impact, creating ideal conditions for bacterial growth. Morrison began the painstaking process of debridement. Using scalpel and forceps, he carefully removed dead and infected tissue, working outward from the wound in concentric circles. Every piece of contaminated material had to be excised, but he had to preserve as much healthy tissue as possible, particularly the major blood vessels and nerves that would be essential for the leg to function. It was delicate work, requiring both the boldness to cut decisively and the precision to avoid causing further damage. Chen worked opposite Morrison, using suction to keep the surgical field clear and pointing out areas that required additional attention. The two men had developed a wordless understanding over months of working together in operating rooms across Europe. Chen anticipated Morrison's next move, prepared instruments before they were requested, and offered quiet suggestions when Morrison's view was obscured or his hands needed a moment's rest. Hours passed. The surgical team worked in near silence, broken only by terse exchanges about suture materials, requests for irrigation, and Martinez's periodic updates on the patient's vital signs. Richter remained stable, his young body proving more resilient than Morrison had dared hope. As the debridement continued, Morrison began to see a path to success. The major vessels were intact, the nerves appeared viable, and while the bone was badly damaged, enough healthy tissue remained that healing was theoretically possible. The most critical moment came when Morrison had to decide how to stabilize the fractured femur. Traditional casting would be inadequate given the severity of the break and the amount of tissue that had been removed. Chen suggested a technique he had read about in recent medical journals: external fixation using metal pins drilled through the bone above and below the fracture site. It was experimental, rarely used in field conditions, but it would allow access to the wound for ongoing care while providing rigid stabilization. Morrison agreed, and together they carefully drilled the pins and connected them with an external frame fashioned from whatever materials the field hospital could provide. The result was crude but functional, a testament to both surgical innovation and the improvisational skills that war demanded of its medical personnel. With the bone stabilized, Morrison began the final phase of the operation, closing the wound in layers while leaving drains in place to prevent fluid accumulation and allow monitoring for any recurrence of infection. As the last suture was placed, Morrison stepped back from the table. 8 hours had passed since the first incision. The team was exhausted, their backs aching from the prolonged standing, their hands cramping from the precise, repetitive motions of surgical technique. But they had done it. The leg remained attached, the blood flow was restored, and if luck and penicillin held, Hans Richter might walk again. Saving Richter's leg in the operating room proved to be only the first battle in a longer war against infection, complications, and the inherent fragility of traumatized tissue. The days following the surgery were critical, a period when success could still slip away despite the hours of careful work. Morrison knew that in battlefield medicine, post-operative care was often more important than the surgery itself, and for a procedure as extensive as they had attempted, vigilance would be essential. The immediate concern was infection. Despite the thorough debridement, bacteria could still be lurking in tissue that appeared healthy. The newly available penicillin represented a revolution in medical treatment, but its use was still being refined, dosing protocols were uncertain, and supplies were limited. Morrison ordered aggressive penicillin therapy, far exceeding the standard protocols for wound treatment. Every 6 hours, a nurse would administer an intramuscular injection of the precious antibiotic, and Morrison personally checked Richter's temperature and wound drainage 4 times daily. The external fixation device, while mechanically sound, created new challenges. The pins penetrating through skin and bone provided potential pathways for bacteria to enter. Chen developed a meticulous cleaning protocol, treating each pin site with antiseptic solution and carefully monitoring for any signs of inflammation or discharge. It was tedious work, requiring patience and attention to detail, but Chen approached it with the same intensity he had brought to the surgical suite. Nurse Lieutenant Patterson became Richter's primary caregiver, a role that required not just medical skill but also patience and compassion. The language barrier was significant. Richter spoke only German and limited English, while Patterson knew only a few German phrases learned from other POW patients. But they developed a communication that transcended words. Patterson learned to read Richter's face, to recognize the subtle signs of increasing pain that might indicate infection, to distinguish between the discomfort of healing and the warning signals of complications. On the 3rd postoperative day, Richter's temperature spiked to 103 degrees Fahrenheit. Morrison examined the wound and found early signs of inflammation around one of the pin sites. It was not yet serious, but it represented exactly the kind of setback that could cascade into disaster. He increased the penicillin dosage again, added sulfa drugs to the regimen, and began twice-daily wound irrigations with saline solution. For 48 hours, the outcome hung in balance. Richter drifted in and out of consciousness, fighting battles that the medical team could support but not fight for him. Then, on the 5th day, the fever broke. Richter's temperature normalized, the inflammation around the pin site resolved, and the wound drainage began to look healthier, changing from the murky fluid of infection to the clear serum of healing tissue. Morrison allowed himself a cautious optimism. They were not out of danger, complications could still arise, but they had cleared the first major hurdle. As Richter's condition stabilized, a new challenge emerged. The young German was becoming aware of where he was and what had happened. Through the translator, he learned that American doctors had saved his leg, that they had spent hours in surgery and devoted scarce resources to preserve his ability to walk. His reaction was complex, a mixture of gratitude, confusion, and guilt. He had been taught that Americans were the enemy, that they fought a war of annihilation against the German people. Yet here were American medical personnel treating him with a level of care that exceeded what many German military hospitals could provide to their own soldiers. Morrison visited Richter each day, not just to assess his medical progress but to talk. Through the translator, they discussed life before the war, family, hopes for the future. Morrison learned that Richter had been conscripted at 17, thrown into combat with minimal training, and wounded in his first major engagement. He was not a Nazi ideologue, just a frightened boy caught in circumstances beyond his control or understanding. These conversations affected Morrison deeply. He had spent years treating the wounds that German weapons inflicted on American soldiers. He had seen the results of German artillery, machine gun fire, and bombing raids. Yet here was a German soldier who was simply another young man, not fundamentally different from the Americans Morrison treated daily. The realization was both unsettling and profoundly humanizing. By the end of the 2nd week, it was clear that the leg would survive. The bone was beginning to heal, the soft tissue was regenerating, and Richter was starting limited exercises to maintain muscle tone and joint flexibility. Chen began planning the next phase of treatment, the eventual removal of the external fixation device and transition to more conventional orthopedic support. It would be months before Richter could walk normally, if ever, but he would walk. Of that, Morrison was now certain. Hans Richter was transferred to a prisoner of war camp in England 6 weeks after his surgery. The transfer was delayed several times to ensure his leg was stable enough for the journey. On the day of his departure, Morrison visited him one final time. Through the translator, Richter tried to express his gratitude, searching for words adequate to the gift he had been given. Morrison simply shook his hand and wished him well, professional to the end but with an emotion in his eyes that needed no translation. The field hospital moved on, following the advancing Allied armies deeper into Germany. Morrison and his team continued their work, performing countless surgeries, saving lives and losing others, operating in a constant state of exhaustion that became the normal condition of existence. But they carried with them the knowledge of what they had accomplished with Richter. It became a story told quietly among the medical personnel, an affirmation that their oath to heal was not conditional, that mercy was not weakness, and that preserving life was victory regardless of whose life it was. After the war ended in May 1945, Morrison returned to Ohio and resumed his civilian surgical practice. He rarely spoke publicly about his wartime experiences, but he carried with him lessons that would shape his entire career. The technical skills honed under fire made him an exceptional surgeon, but more than that, his experience with Richter reinforced a fundamental belief in the sanctity of human life and the physician's obligation to heal without prejudice. Staff Sergeant Robert Chern returned to Johns Hopkins and became a professor of surgery, known for his technical precision and his insistence that medical care should never be compromised by considerations of nationality, race, or politics. He often used the Richter case in his teaching, illustrating both advanced surgical techniques and the ethical principles that should guide medical practice. Lieutenant Mary Patterson continued her nursing career and became an advocate for international medical cooperation. She worked with organizations dedicated to ensuring that the Geneva Convention protections for wounded soldiers and prisoners of war were respected and enforced. Her experience caring for Richter had shown her that nursing was not just a technical profession, but a moral calling. As for Hans Richter, his story took a remarkable turn. After the war, he was repatriated to Germany and completed his engineering studies as he had dreamed. He walked with a pronounced limp for the rest of his life, and cold weather brought aches to his reconstructed leg, but he walked. In the 1960s, through the efforts of veterans organizations, he was able to contact Morrison and thank him personally. They corresponded for years, an unlikely friendship between former enemies that testified to the bonds that shared experience can create. Richter became an advocate for reconciliation between Germany and the United States. He spoke to student groups about his experience, emphasizing that even in war's darkest moments, individuals can choose compassion over hatred. His message resonated particularly with young Germans struggling to understand their nation's history and seeking a path toward a different future. The broader significance of this case extends beyond the individuals involved. It represents a principle that military medical personnel have upheld across countless conflicts, that medical ethics transcend national boundaries and that healers serve humanity itself, not merely their own side. The decision Morrison and his team made was replicated thousands of times across the theaters of World War II and in every conflict since, though most cases went unrecorded and unremembered. The story also illuminates a profound truth about warfare. While conflict brings out the worst in humanity, it also creates circumstances that reveal the best. The same war that produced the Holocaust and the firebombing of cities also produced acts of mercy, sacrifice, and moral courage. Morrison and his team were not unique in their compassion, but their success in saving Richter's leg against overwhelming odds made their case memorable. In the decades since World War II, battlefield medicine has advanced dramatically. Antibiotics are more powerful, surgical techniques more refined, and evacuation systems faster and more efficient. But the fundamental principle that Morrison demonstrated remains unchanged: that every life has value, that medical personnel are bound by oath to heal all who come under their care, and that preserving human dignity in war is not idealism but essential to preserving our own humanity. The barn in France where Morrison operated has long since returned to agricultural use. The field hospital moved on, and the war moved on, and eventually the soldiers went home. But what happened in that makeshift operating theater on a gray November afternoon continues to resonate. It stands as a testament to what medicine can achieve when skill combines with compassion, when technical excellence serves ethical conviction, and when the healer's oath is honored even when honoring it is difficult and costly. In saving Hans Richter's leg, Captain James Morrison and his team did not end the war, did not change the course of history's great movements. But they changed one life, completely and irrevocably. They gave a young man his future back when that future seemed lost. And in doing so, they demonstrated that even in war's cruelest moments, mercy remains possible, that hatred need not be answered with hatred, and that the simple act of healing can be its own form of resistance against the dehumanizing forces of conflict. This is the legacy of those American Army medics, not just a saved limb, but a saved soul, and a reminder that the highest calling of medicine is not to serve nations or causes, but to serve life itself, wherever and in whomever it is found.